I now request, okay, the next expected session is also coming now. I now request Dr. Samudi Shankari ma'am, the senior most fertility specialist of the state and wonderful human being, to come to the stage to chair the next session, along with Dr. Divya Selvamani ma'am, the medical director of Srishti Hospitals.
I congratulate Dr. Aruna and Dr. Ashok and the team for making this happen in spite of this prohibiting weather. Great applause to them. And I take this opportunity, I don't know, I would have grabbed this opportunity from anybody else because I'm about to introduce a great person and whom you had the kind of big opportunity to just listen to him. So I've been there listening to him multiple times. I've been super impressed. And Osama Shauki is an emotion, is not just a name, it's just an emotion of, you know, a kid-like enthusiasm, courage, lots of love, and what can I say, perseverance, innovation, intelligence. I can keep adding on to the list. I don't know, he's seen most parts of the India rather than anybody else of us in this group, or I mean, let alone here, I mean, the rest of India as well. And in spite of he kind of hails from the great land of Nile, and his university, you should see, I had the opportunity to visit him in Egypt, and the university is beautiful, one of the most kind of, the oldest universities there, and he's a senior most professor there. And he has been the game changer of how knowledge has to be passed on to the younger generation of aspiring gynecologists. And he's the Dronacharya of hysteroscopy, I would say. Instead, he's got the hysteroscope in his hand. And like I said, it's always my pride and privilege to introduce him. And yeah, I can't wait to be inspired like how you are. And without further ado, the king of hysteroscopy, the magician himself. Thank you.
I welcome Dr. Shauki, the king of hysteroscopy and a luminary in the field of hysteroscopy, to deliver the lecture.
I have to give a kiss for that. Thank you very much. Thank you. You made my day. Thank you. Thank you very much. Do you agree? A very lovely good afternoon, ladies, and very few gentlemen today. Can you read that? Oh, don't break my heart. I spend all the night on Google Translator to find the Tamil. It's Ongali and Budan. Okay, welcome, friends. Well, my name is Osama Shawki. I'm from the land of ancient civilization, from Egypt. And all my life, I am working to make people be happier. If this can be achieved through hysteroscopy, I will do that. So this is the Times News Cairo-based doctor badge for hysteroscopy. And as I showed you yesterday, my collection of videos reached 2,000 videos on YouTube, which viewed by 3.6 million people. Every speaker show up by the number of his publications. Okay, but this is my pride. I show you how to do it, not write it on a paper to tell you how to do it. Well, some rambling around the world in 69 countries, teaching hysteroscopy, but definitely India is the most visited country in my life. More than 168 training programs, doing more than 3,000 challenging operations. They became now 3,021 because yesterday and before I did 21 cases. So the counter is counting, and hands-on training for more than 5,000 gynecologists in your country. Thank you. I tried to translate in Tamil language. I said, my hands on your hand and my heart with your heart. Is it correct? Okay. Hands-on is the only way to give the skills, not to teach by lectures and slides. So my technique of hands-on to get the feeling from my nerve, from my muscle fibers, to know how to do it. Definitely, I enjoy knowing people all over the world, but again, India is in the center of my heart. And as I told you yesterday, in the West, the emotions of the people is very cold, and the colors is only black and white. Look at these colors. So now you know why I fell in love with all of you. And it's my privilege to stand in front of Dr. Shankari and Divya. They are the second most important ladies in my life after my wife. Okay. As I said, Divya, my mission is not to teach you surgical skills. My mission is to inspire you. And when you get inspired, you will achieve. Teaching you how to do TLH and you became the best doctor doing TLH does not mean you will be a happy person in your life or achieve your dream. So one of the stories that I'm proud to tell about this very young lady doctor from Jodhpur, Dr. Sonal Parihar. She's my student. She invited me to her center. She has a very humble, small hospital, not like A4, okay? And she wanted to make promotion for himself, that Osama, the king of hysteroscopy expert, is doing a training program. And I visited her, and in the operating room, she clicked this picture. I told her, Sonal, you are a cheater, because the Photoshop makes us very beautiful, and we are not like that. I gave a lecture about motivation that day. And then I asked her in the operating room, Sonal, what is your dream? She said, okay, Dr. Shawki, I don't want to speak about my dream. I said, why? Tell me what's your ambitious. She said, it's another story than medicine and than being a gynecologist. Since I'm a child, my dream, looking to those Bollywood stars and cover girl magazines, beauty competition, my dream was to be one among those. But it is impossible. To the Sonal, you listened to my lecture this morning. Don't you think that you are able to reshape your future? And I spoke to her about a study done by a great psychologist in the United States, Jim Clear. He said, the greatest invention in our age is not the nuclear power or the internet. The greatest invention is that every human is able to change his career and future by resetting his mind. I saw her eyes sparkling. I felt that I could ignite the passion in her heart. And a couple of months later, she sent me this picture, Sonal Parihar, Mrs. India and Earth. Give an applause to this lady, please, not to me. It's a story about achieving your dream. Well, let's now talk about our practice. Everybody is proud to be a gynecologist, but we are the only specialty that up till now we do blind procedures to take a biopsy from the cavity of the organ we are treating. Have you ever heard a urologist removing bladder polyp by curettage? Okay, the urinary bladder is equal to the uterus, okay? You are laughing, okay? Because you feel that it's shame on us that we go blindly and scrap the cavity trying to find the pathology. So let's stop this procedure. And it is my slogan, the hysteroscope will evolve to be the gynecologist stethoscope. As every cardiologist has his own stethoscope, every gynecologist should have your own hysteroscope. Osama, does it mean that I will buy the full tower? No, you buy scope and sheath only, and you put it in your bag. That's yours. You're going to operate in A4 hospital, you take your equipment, and you tell Aruna, I'm gonna use your only camera, monitor, light source, but I have my own telescope. You understand the suffering, what I faced in you, the lens is damaged, because this equipment is very fine. It's not for public and common use. So everyone should have his own hysteroscope. And it's time now to stop using this machine gun, okay? The most scary instruments in office practice. You claim that gynecology became modern. What is modern we are doing? It's only the examination chair. But the same procedure using that old speculums. Let us compare the diagnostic tool we have in the office. Look, you cannot compare an image, black and white, with a vivid picture of the cavity of the uterus. So, my message to you today that hysteroscopy is not only for the uterine cavity. Those who attended my workshop, they have seen how can we examine the vagina, the cervix. You can replace colposcopy, cavity of the uterus, and even the proximal part of the fallopian tube. So, no more painful examination. You all know this experience. Is it correct in Tamil Nadu language? Yes. Fear. I am put the picture which reflect the real feeling of the patient in your office. She is afraid, especially when you enter the examination room like that. We are monsters, okay? You don't feel it, but the patient is terrified and she is hearing this the metal sound and she's scared. Sir, what you will do? Shut up. Don't you agree with me that gynae examination is one of the most humiliating, insulting moment in the life of a woman? She entered the office of a stranger, especially a man, take off her clothes, expose her private parts. It's very embarrassing. We have to find another solution. And when the patient asks you, why you put this machine gun inside me? Madam, shut up, I want to examine your vagina. When you put it, actually, you don't see the vagina. Am I correct? So this is a surprise for you. Since you started practicing gynecology, you have never even inspected, really, the vaginal canal. You put this metal thing and you see only the cervix. So, time for change. Time to make vaginal examination more accurate, better vision, more convenient to the patient, more comfortable with dignity. When you put the telescope into the vagina, like we have seen in the workshop, close the vulva, distend the vagina, look at the monitor. Isn't this respect? You are not looking to her private parts, okay? You are standing by the side, and madam, look with me, this is the inside of your vaginal canal. And it's very helpful in many situations, like those patients who are very touchy, and she screams if you only touch her vulva, okay? How you put this speculum inside? And for postmenopausal women, definitely you have met them, postmenopausal with very small vulval orifice, with atrophic vagina, and very sensitive to touch. How you examine the vagina? What about virgins? So my technique of vaginoscopy will definitely be a solution in modern gynecology. In the office, you insert the telescope gently, no speculum, no teneculum. Open the water distension, expand the vagina, and welcome to the cavity of the vagina. Look at the beautiful view. This is postmenopausal patient. And you can see atrophic changes in the vagina, and this red color, this is the classic strawberry vagina of trichomonas infection. So imagine how it's comfortable for the patient to be examined this way without putting any instrument. And you can inspect all the walls of the vagina, anterior and posterior, the fornices, and the portio vaginalis of the cervix. Let us now see how you can see the vagina nicely by vaginoscopy and look inside the cervical canal together. That's vaginoscopy. Lateral fornix, posterior fornix, portio vaginalis of the cervix. This is Hindi song, not Tamil. Look at the red color of the trichomonas infection. Let's go inside. An endocervical polyp. Look at the magnification. You will never see the endocervix like that. Well, Angelina Jolie is famous about the lips, okay? Let us see the lipsticks of the cervix. You have seen a lecture about colposcopy now. That's even more accurate than colposcopy because it can show the external surface and the endocervical canal as well. That's cervical erosion or cervical ectopy. And what is this? Anybody have a clue about what is this lesion? That's a deep infiltrating endometriosis. Maybe some of you, they say, this is rare, Osama. We don't say that. We don't see that because you don't examine with my way. When you put a speculum, you'll not see the whole circumference of the vagina. And it's not only to see and diagnose, but also to treat. That's a new concept. What you are seeing now is operative vaginoscopy. Operative endoscopic procedures inside the vagina. That's a deep endometriotic cyst in the portio vaginalis and in the lateral fornix. You have a diagnosis for that? Yes, that's a longitudinal vaginal septum. It's a rare anomaly bisecting the vaginal canal into two halves. So how you put a speculum and diagnose that? Okay. So what I'm bringing to you today is a new vision for office gynecology. And not only to diagnose, but also to treat. This is operative endoscopic vaginal surgery. This septum divide the vagina into two halves. Under vision, it's very clear. Anteriorly is the bladder, posteriorly is the rectum. You will never injure any structure so long you have this clear view. Using a monopolar or a bipolar, all the way up till the cervix. Now approaching the external os, you see, it's not two cervix, it's a one cervix divided by a septum. So it is a vaginal, cervical, uterine septum. Procedure accomplished in less than 2 minutes. And no need to take sutures after that. Well, colposcopy is a modern tool for the office examination. As you have listened in the previous lecture, you can examine the portio vaginalis and the squamocolumnar junction. But is it able to enter the cervical canal? No. And one more thing. The colposcope is a magnifying lens looking from far away to the cervix there. But the hysteroscope can travel, can come very close, and you can make contact examination of cervical tissues. Look at this case. This is a case of postmenopausal bleeding, and the doctor subjected her to 2 times DNC but the bleeding continue because he doesn't know that the pathology is in the cervix, not in the cavity of the uterus. Enjoy this. This is the internal os, and the pathology is in the cervical canal. You can see the endocervical mucus secreting glands. How to treat this? Very simply, in the office, using the grasper. Catch, twist, and come up. This is the most accurate, the most precise intervention to take this polyp out and send it for histopathology. All my videos are the real time. It's only 1 minute. So what about difficult cases for dilatation, like the cervical stenosis and adhesions at the internal os? This is the most frustrating for gynecologists, failure to enter the uterine cavity. Whether you want to take a biopsy or you want to do embryo transfer or whatever, this problem is a frustration to most gynecologists. Here, I advise you not to use the metal blind dilators. Use the soft power of the jet of water. Enjoy this one. This is a case of ischial adhesions, stenosis of the internal os. This is the endocervical mucosa and very narrow internal os. And you can see obviously the adhesions around the internal os. Any attempt for blind dilatation will go into force track. But under vision, you can see well. Enjoy that. This is the power of hydrodissection to release the adhesions and open the way. Very slow, gradual insertion. Many of the cases operated yesterday was like this. The internal os was very narrow. And access to the uterine cavity under vision. This is the way it should be. Well, this video I showed yesterday, but maybe I see some newcomers, so I repeat it again today. But I say a little joke, okay? I always say it in my lectures. I could see some ladies taking pictures and videos for my presentation. So I'm sorry, you have to pay for that. Divya, I take 1 kiss for every video clip. And for the gentleman for free. I'm just joking. Well, a mission impossible, which means that no surgeon was able to enter through this internal os. It's a pinhole, fibrosed, fibrotic, stenotic, like the cases that Dr. Aruna referred to me yesterday. So it's a mission impossible, and everybody know who the hero of Mission Impossible. You know him? Who? Exactly. So I had to call him, Tom Cruise, to come and help. He said, no, I cannot do hysteroscopy. Can we try somebody else? Even Salman Khan cannot. Well, let me share with you how to negotiate a very narrow cervix safely and enter the cavity without force track, without perforation. Dilatation by Heger is a blind procedure. You are very lucky to go through this pinhole cervix. But when you have this view, you have a pinhole clue. Like we did yesterday in the workshop. It was yesterday, huh? Yes. Using the scissors as your dilator. Insert the scissors through this pinhole and dilate. I call it dilatation under vision. You will never do a force track so long you see well. It's a combination of the power of water and visual access. Now the internal os is better and you can go inside and find the pathology. 2 small polyps. Well, let me move from the vagina and the cervix to another concept in gynecology. My friends, the dermatologists, they get the diagnosis by inspection of the skin. They can know this is normal skin, this is dermatitis, this is psoriasis, this is allergy. Why not? Gynecologists could be able also to look at endometrium and say, this is proliferative, this is secretory, this is hyperplasia, and that's carcinoma. So, Divya, this is my dream, that every gynecologist should be able to look at the endometrium and get the diagnosis. Like this. That's a typical endometrial hyperplasia. Osama, how could we know? You have to see more. Like a dermatologist, the more you see, the more you get eye examination, visual inspection diagnosis. That's a hyperplasia. And this is a hyperplasia treated by Mirena. So Mirena was used here as a treatment solution for endometrial hyperplasia. And by hysteroscopy, you can see wonders inside the cavity. Look at the blood vessels. Look at the white deposit. Nobody has spoken about the things. Nobody has seen the things before. It's really amazing. All this congestion, increased vascularity, increased thickness of endometrium, that's an endometrial hyperplasia. That's a provisional diagnosis until the histopathology comes. I want to show you something impressive as well. Look here. Look at this blood vessel. You can see even the branches of a minute capillary of the endometrium. I'm sharing with you wonders and wonders of hysteroscopy. Yesterday, I was asked from some colleagues, how can we diagnose carcinoma? And my answer to them, it is unmistakable. When you see it, it's very evident. Going from the internal os, and then you face this necrotic, vascular, friable tissues. This is a classic diffuse CA, carcinoma of endometrium. That's endometrial carcinoma, diffuse, filling the whole uterine cavity, and this is a localized cauliflower mass. Criteria of malignancy, friability, congestion, and increased vascularity. Well, polyps, the most frequently encountered pathology, whether in infertility or perimenopausal. How to diagnose? By the way, this video is very important. This is the endocervix, huh? This is the endocervix, and this is the cesarean scar. You remember the discussion about the niche? The cesarean scar is very low. So this is a polyp peeping out from the internal os. So let us follow and see where is the pedicle. This is the cesarean scar. Imagine the pedicle coming from just near the cornea. Some of you will say, Osama, why not to grab and pull? You will cut it, but the pedicle is still there. It will grow again. Let me show you more impressive polyps. Let's go inside the uterine cavity. The polyps are dancing, actually. This is a plethora, party of polyps. How to get this good view? Come to my workshop and I will teach you. I don't think anybody of you have seen this number of polyps before. And this is a localized polyp which is very suspicious on the posterior wall. blind D and C will never remove these polyps. You have to do it under vision. We did one case of polyp in your hospital yesterday. And not only see, but see and treat. On the spot, you can introduce the scissor, cut the polyp, and take it for histopathology. And the office hysteroscopy sheath diameter is 4 millimeter. 4 mm. What is the diameter of the uterine sound? Can anybody tell me? 4. What is the diameter of the copper IUCD inserter? 4. And the Mirena is 5 millimeters. So the office hysteroscope is less than the diameter of the Mirena. So you can do it in the office. And this is real time. It's only 10 seconds to cut the polyp. Attack the pedicle. Don't cut it completely. Leave it attached so you can go by the grasper and get it out. You see that? And once the polyp is loose and free, it starts to dance. Or to run on the treadmill, okay? You see the exercise, Divya? It's a very energetic polyp, okay? How to make it dancing like this? You have to come to my workshop, okay? Well, this is a nice case and very interesting. This bilateral 2 polyps, each one coming from each cornea. Only the old people will enjoy this melody, okay? The youngster doesn't know it. Okay? This is Raj Kumar, okay? You know it? You see the pedicle? And it's a vascular pedicle. Well, I love this song because it reminds me when I was a child. This was the Indian movies coming to my country, okay? Sangam and Suraj. So, using the scissor, you attack the pedicle. This is tubal ostium, and the polyp is exactly in a strategic location at the tubal ostium. So, you see how nicely and easy you can, this is already 1 polyp finished. Push it aside, and let's attack the second polyp, which at the base is posterolateral at the right cornea. Okay, let's go and see how can, using the scissor, no need for electrosurgery, no need for morcellator or shavers. By the simple scissor, you can finish the job. This is the pedicle, okay? Everybody is concerned about the vascular pedicle. Will it bleed or not? Let's see. Let us see. Okay, cut. Cut more. And now you will see that the polyp is attached only by the vessel supplying it. Should I cut or no? Divya, tell me. Okay, Ashok say cut. And check. No bleeding, all right? And then use the grasper to catch it and get it out. Ashok, in my opinion, this procedure is more important to teach people than TLH. TLH, there is another option. You can do abdominal hysterectomy, okay? But for these polyps, how to remove it correctly and precisely? Unfortunately, most people do blind curettage and the patient continue to bleed because the polyp was not removed from the pedicle. But if the polyp is bigger, here we use the resectoscope. You have to cut it into pieces. The small polyp, you can get it out by the, look at the pedicle. Jump over the polyp and pull the electrode from far to near. Some people ask me why you put music on your videos. Because surgery is an art and music is part of the art. You feel it. Don't you feel the synchronization between the music and the movement of the electrode? So If the polyp is large and has a pedicle, should I attack the pedicle? No. If it is large and you cut the pedicle, the polyp inside the uterus will be like an apple inside a Coca-Cola bottle. You cannot get it out. And it's important to get it out for histopathology. So, that's Tamil. Just cauterize the pedicle and resect. Move the electrode slowly. Don't go out to clean. Push the piece to inside and continue. You understand? You understand? I know it's afternoon and you're tired and your head is dropped. So I want you to wake up, okay? Look how to move the electrode. This is the pedicle. It takes like 3 to 4 minutes to finish. This is the end of the procedure. Enjoy the view. Thank you. I promise you, in my next visit, I will speak Tamil language, okay? Well, the last thing I'm sharing with you, let us save the uterus. The uterus is the most valuable organ for the mankind. Compared to the heart, compared to the liver and the kidney. This is the organ which brings life. People say the heart is the organ of life. Okay, but the uterus, it is the organ that brings life. It is very generous organ. It accommodates us for 9 months. You remember that? It was the best time in your life. No fight with husbands. No responsibility, no work, no wake up early. We lived the best time in our life inside this room. Whatever outside the temperature, freezing cold or very hot, you are in that jacuzzi, 37 degrees. And your head on the pillow of the placenta. You are listening to the musical heart rate of your mother. And I repeat always that the moment we come out from that paradise, we cried. And again, the moment I came out, Osama Shawki, since my birth, I am committed to come back again as a hysteroscopic surgeon, okay? So, you'll be surprised to listen from me that the latest statistics from the WHO about the number of hysterectomy in the world. There is 20 hysterectomy performed every minute. Can you imagine? So in one slide, there are 20 women in the world lost their uterus. In the United States, 500,000 hysterectomy every year. And what about India? Can you guess? I don't know if it's a joke or not, but this told to me by Hafiz Rahman and Nikita. You know Nikita Trahan? Nikita Trahan is a good surgeon. She told me, Osama, there is a city in India which is all women uterus free. Is that true? It's true, okay. No uterus in the woman. Even 18 years old, and I have seen it myself. We have a WhatsApp group with my Indian friends. One doctor, but seems very aggressive, he wants to file a complaint against his colleague, but he has the right. Because he received a patient, 18 years old, hysterectomized, a virgin. And you know what is the indication? I'm not joking. The indication was knee pain. So he convinced the patient, because of the knee pain, we remove the uterus. And also in my country, every gynecologist in my country have 2 clamps in his pocket, okay, ready to do hysterectomy anytime. So let us save the uterus. Let us find other solution. The other solution is that endometrial ablation resection. And my last visit before I come to you here, I was with Hafiz Rahman in Delhi, and we made a workshop about only endometrial ablation as an alternative for hysterectomy. My friend, thin guy, correct. The uterus is a thin guy. Am I correct? I'm learning Tamil just only for you. So, and the lining endometrium is that white thing, which is every month bleeds, or any pathology happen makes it bleeding. So why to remove the whole coconut? I swear to God, I went to the market, I bought a coconut, and I made this picture only for you so you can understand my procedure. You got it? That's endometrial resection. We remove the inner white lining and leave the skeleton of the uterus, so the woman will go home in 2 hours with her uterus is intact. And by the way, women love their uterus. It's part of their identity. Whatever you try to explain to her that it's not related to sex and life, she believes I'm not a woman anymore if I lose. So endometrial ablation resection is an excellent alternative for hysterectomy. Let's enjoy the procedure. That's a case of a dysfunctional uterine bleeding. You can do it for dysfunctional uterine bleeding, simple hyperplasia, even fibroid uterus. If she has a multiple fibroid, the bleeding is not from the myoma, it's from the endometrium. Remove the endometrium. What about the fibroid? Forget it. It will atrophy by time. Look at that. This is the posterior wall. Shaving, look at the myometrium. Ashok. This interlacing fiber, this is the myometrium. So you remove the endometrium down to the basal layer. It will come again. And this is the real time. Posterior wall finished in 20 seconds, okay? And then this is the lateral wall. Starting from the cornea, start from high up the cornea, shaving the endometrium all the way down till the level of internal os. Just stop at the internal os. And now this is the anterior wall. This is the real time. So bleeding will either stop complete amenorrhea, or even if she have bleeding, it will be very minimal. She can live without. So this is almost final view. Everything is white except only the fundus. This is the most difficult part. This is the most technically difficult part. To remove the fundal endometrium, like that. I am sure that all of you fell in love with this procedure. I can feel you, okay? But also I want to warn you, it's not easy. It's not easy. And if you don't do it perfectly, the patient come back with bleeding and worse symptoms, bleeding and pain. So this is the way you should look at this. This is the most difficult part. The corneal angle. Don't leave any pinkish islands. So let us save the uterus. This is alternative than hysterectomy. I am finishing my presentation by some exciting, entertaining procedures. Hysteroscopy for the tubal ostium. Definitely Aruna needs me. She needs me very much for the cases of hydrosalpinx, because the patient has previous laparotomy, bilateral hydrosalpinx, and she's going for IVF. And when Aruna looks at the abdomen of the patient with many scars, she's afraid to do laparoscopy. Or if you do laparoscopy, you find extensive adhesions. So here, hysteroscopic ostial occlusion is another alternative. How to assess the tubal ostium? A new technique or a new procedure that I designed to study the tubal ostium. Enjoy this one. This is before the last. I published this in YouTube 12 years ago. You know, Divya, last year I found somebody published this and call it with his name, all right? Look how to play with the bubbles. Look carefully to see how I enjoy playing with the bubbles. You hit the balls like billiard balls. Okay, look at that. And look at this part. This is very nice. Hit the ball and move. Hit and move. So, did you like that? Wake up. Why you are sleepy? Wake up. Move your head. Move your head. Okay. This is the last thing I'm sharing with you. Since I was a student, I was so amazed by that capacity of the tiny sperm, how he can reach to the rendezvous site with the ovum at the outer third of the tube. You know that from physiology, okay? The sperm travel all that to reach the outer third of the tube. So I learned from the physiology that the sperm is about 16 to 50 microns, and it has a tail, and it has a head and a cap. This is how I give my lecture to the students. I'm doing the same with you. So the sperm is like a decent gentleman. So when he enters the uterus starts to contract, and the uterotubal peristalsis create a suction to deliver the sperm till the tubal ostium. And at the tubal ostium, the sperm uses his tail to pass. And then when he meets the ovum as a decent gentleman meeting a lady, he take off his cap and release the enzymes. And these enzymes knock on the door of the zona pellucida. But the ovum is very high ego. She wouldn't allow him to enter from the door. So the first batch of the sperms, they reach quickly, they consume their power, and they release their enzymes. They knock on the door, but the ovum refuses. And then the wise sperm, the mature one, stay down, patient, until the early one, they open the ways for him. And then the wise one travel, find his way, the uterotubal peristalsis suck him up, and when he reached the ovum, he find her resistance become weaker, okay? She lives only 24 hours. So if she doesn't accept that groom, there is no other chance. And her wall became weak because of the previous knocking. So when he raised his hat, released his enzyme, she opened the door, and he can go with his head. And immediately after he go with his head, the zona pellucida fuses back again and cut his tail. Why cut his tail? So he cannot go out again, all right? So this mechanism occupied my mind, so I share with you now an experimental work I did to show how the uterotubal peristalsis help the sperm to reach up. Okay, how I did that? How I bring sperms and put it inside the uterus and look at it, okay? It's difficult. And even if I have the sperm, it is invisible. So I'm sharing with you how to invent. I brought a vial of antibiotic powder. The antibiotic powder made of particles. And the particle size is almost equal to the size of the sperm. And I put few drops or few milliliters of methylene blue. And shake slowly. Don't shake well. If you shake well, the particles dissolve. Shake slowly so these particles will take the stain of blue. And I injected this solution inside the uterus. Are you eager to see what happened? Raise your voice. Are you eager? Okay. These are the sperm-like particles. These are sperm-like particles inside the uterus. And now focus your eyesight near the ostium and see what will happen. They look really like sperms, okay? Look what will happen when they come near the ostium. Now, look at this. Do you appreciate the suction? Enjoy. Enjoy till the end. It takes 1 minute. Again. Never happened in the history of hysteroscopy or in medicine. To show the mechanism of sperm transfer and migration. Once more, the uterotubal peristalsis with suction power. Aruna, don't miss that. This is my finale and my best. And now you will see another phenomena. Not only the sperms, but the methylene blue dye. Now, how the methylene blue dye travel. Look at that. the suction power of the tubal peristalsis. Pull out the methylene blue. Look, it goes to the ovulation dominant side. Thank you, thank you, thank you, thank you, Aruna, thank you, Ashok, thank you, Divya, thank you, Dr. Shankari. I love you all. Thank you very much.
Thank you, Professor
Thank you.
Shaki, for the interesting musical presentation, which I think it's one of its kind. He has traveled almost in 48 countries and trained 3,000 doctors in
That's in
business
India only.
domain.
No, India
And,
only 3,000.
yeah. And once upon a time, about 8 years ago, when he was presenting in an ASCOG conference, I thought that this magician would be able to come to our place. But it happened. He came nearly about 8 to 9 times to Chennai.
Can you imagine?
Yes,
9
yeah.
times in Shruti Hospital, enjoying the hospitality, and when I visit them, they bring me the most terrible cases, okay? The elephant myoma, the impossible septum, the impassable cervix. But I cannot deny that they give me the best hospitality and the best prawns and seafood I ate in my life in your place. But actually, I feel that they are my family. When I come to them, they are not my friend. They are my family. Whenever I see you, maybe I don't remember all the names, but your face is implanted into my left ventricle. So you will always be in my heart.
Thank you so much for the wonderful presentation.
Thank you very much. Thank you. Thank you.
Thank you, sir. Thank you for the wonderful session. It was no less than a Bollywood movie. Let us all give a standing ovation to the king of hysteroscopy, the universal boss. Thank you, sir. Thank you, sir. I also thank our respected chairpersons, Dr. Samudi Shankari ma'am, the lady superstar of fertility, and Dr. Divya Selvamani ma'am, the medical director. Thank you, ma'am.